Okay. Good day to everyone. Good morning, good evening, and good night to the people who are all over the world who have joined this webinar. Um, so this is an initiative and a joint collaboration. I will say the academic and research collaboration between the Society of Integrated Pain and Palliative Care and the Pain Institute of Spain, as well as Smart Pain Technology International. So today we will be discussing about interventional pain management in cancer pains, especially restricting to cancer pain itself. So here we have Dr. Manuel Herrero, who is a anesthesiologist and a pain physician from Madrid, Spain. He had done his fellowship in interventional pain practice and is a certified interventional pain sonologist by the World Institute of Pain. Also, is a faculty of the World Institute of Pain. Is also the part of the latest Spanish Pain Society executive team. Is also president of the pain committee at Puerta de Hierro Hospital from Spain and cancer pain clinic coordinator at Madrid. He's also the founder and director of the Pain Institute of Spain, and he's also holder of the European Diploma in Pain Medicine by EFIC. And not but the least, his topmost, I can say, achievement, or I can say the passion and the hobbies. He's also excellent musician and he's a part of formal band. Mahesh, would you like to say something, and we will start from there.
Thank you, Professor Raghu, for this introduction. Now, for all the members who have logged in for this webinar on cancer pain, Professor Raghu is our chairperson for today's event. He is a professor in palliative medicine in one of the leading hospitals in India in cancer, called Tata Memorial Hospital. And it's a pleasure to be part of the audience and listen to these stalwarts. And we will proceed, Professor. You can take over. Thank you.
Right. Thank you very much. It's a pleasure to be here with all of you. I want to thank the Society of Integrated Pain and Palliative Care, the SIPP Society, for inviting me one more time here. This is not my first time doing a lecture with you. I want to thank especially Dr. Tota and Dr. Mahesh Menon for this invitation. Let me share the screen. Okay. Right, this is my lecture. It's about the interventions in cancer pain. It's a very large topic, but I will try to focus on the principal interventional techniques and the patient selection for your knowledge. Before starting the lecture, I want to remind some pictures, because I'm a friend of Dr. Mahesh Menon since 2018, I guess. We were doing the EDPM exam, and we had a very good time there. It's a very difficult exam, but it's worth it, and we are now very good friends. Mahesh and me and the other guys are Mick Palotas, Jesus de Santiago, and Sunil Danasi. So I think I encourage people to take those kind of exams to improve in their knowledge and in pain education, and to meet some new friends that could be friends for new networkings and collaborations in the future, like this. This is another picture in Spain, in Valencia, taking the diploma of the EDPM in 2019, I guess. As I mentioned before, this is not my first time doing a lecture in this society. I was doing an online lecture in 2020 about DRG stimulation. It was very interesting, and I want to thank you again for inviting me this time. And let's start with the Pain Institute of Spain, because Pain Institute of Spain was an idea that I got during the COVID pandemic. I needed to do some program for education in pain management in Spain. Most of the programs are online, but we got now now that we can do practice sessions, and we got a specialized courses in Spain for people that are working in Spain and for people also from Spain, that are in an e-platform learning from pain procedures, from lectures. We got a lot of multimedia contents of interventional techniques, and we got some intensive courses too for people that want to come with us to learn from us during 2 weeks in an intense course called the Interventional Pain Training Program. And they will enjoy watching procedures all the time, morning and afternoons, during 2 weeks in different hospitals from Madrid with the principal team of the Pain Institute of Spain. So we are now in our 2nd year, and we are growing a lot, and we are very happy about it. And now we want to collaborate with other societies that like the SIPP. So we are very grateful for that. And I wanna thank again this collaboration. I have no disclosures for this lecture. We will start talking about some epidemiology about the cancer pain. Unfortunately, 41% of the whole population will suffer from some type of cancer. The pain is a high prevalent symptom, and it affects the quality of life of the patients. If we group all the principal symptoms in cancer patients, the pain would be in the 2nd place, just after the fatigue. And if we ask the patients about scoring the intensity of the pain, 1/3 of them will answer that the pain is severe. So it is a challenge for us to treat this type of cancer. What does the pain mean for these patients? It's a bad prognosis in the short term, especially when the pain gets worse, a reduction in autonomy, a worsening of physical and social function, and a worsening of well-being and quality of life. It's a challenge to dignity and a threat for the increase in physical suffering. If we look into the analgesic ladder, but not the analgesic ladder, because from 2005, the International Association for the Study of Pain changed the analgesic ladder to analgesic lift. This is because we have to treat the patients according to the intensity of their pain. So if you have a patient, it's the first time that you have a patient at your office, and the patient says that the pain is severe, you have to start with strong opioids to treat them. Otherwise, you will undertreat the pain of the patients. And the interventional procedures should be considered as an adjuvant to common analgesic regimens at any stage, and should not be regarded as a last resort. So we have to treat the patients correctly to avoid the undertreatment of those patients. This is a publication talking about undertreatment in cancer patients. The first time that a publication talked about undertreatment and cancer patients was in 2008, and this publication was a study about a lot of patients, a lot of hospitalized patients treated with drugs, and comparing these drugs with the intensity of the pain. So if the patients were treated with drugs lower than the intensity of their pain, we will have a negative pain management index. So we still have a negative pain management index because the patients are treating not so good. So we are improving this index, but we have a lot of work to do, and the interventional techniques are a very good, a very useful tool that we got to improve not only the pain of the patients, but also the quality of life. Because these interventions are performed in a surgery room. Most of the patients are outpatients. The procedures are done using local anesthesia, and most of the times the patients are awake. This is because we need the patients to talk to us if they are feeling something strange or something is going bad, to reduce the risk of complications. The imaging techniques that we use are fluoroscopy or ultrasound or CT techniques, And these procedures have a very high efficacy and safety. The efficacy of the interventional procedures depends, in my point, depends on the operator experience. So we should have a very good pain education and training to do these procedures. In Spain, we celebrate the only course regarding the interventional techniques for cancer patients, because they are, and I will show you very specific interventional techniques for these patients that we have to know about it. We have to know all the tips, all the possible complications, encourage our colleagues to treat the cancer patients with these techniques because they are very, very effective. We should have a correct diagnosis of the pain. So we should know where is the source of the pain. That's why a lot of times the first procedure that we do is a diagnostic block to confirm or rule out the source of the pain. I have to tell you that in cancer patients, we should avoid these diagnostic blocks, especially in patients with visceral pain, or when we need to implant an intrathecal pump to the patients. Because if we do these procedures, diagnostic blocks, we are increasing the stress for the patient, the possible risks, and we are working against the time, because the patients that got an unresectable tumor, they got an evolution, and we need to treat these patients very early, okay? And that's the reason why the moment that should be performed, these procedures for cancer pain are very important. We got a lot of publications regarding supporting the early interventional procedures for cancer pain patients, because the early we do these procedures, the high efficacy we got. The types of interventional procedures, we got a lot of techniques we can perform in cancer patients. You know that the source of the pain most of the times are due to the tumor in 65% of the cases, but we got patients suffering from pain secondary to diagnostic techniques or anti-tumoral treatments, for instance, chemotherapy or radiotherapy, or even the surgeries. And there are a few patients that got pain not associated to the cancers, because there are patients that already have chronic pain, and because of the tumor, this chronic pain gets worsened. No? So we have to treat a lot of types of pain in the cancer patients, and it could be neuropathic pain or nociceptive pain or mixed. And we got very different options to treat those patients. No? If we got neuropathic pain in these patients, we can use pads if the pain is very localized, or radio frequency, or cryo, or spinal cord stimulation. If the pain is somatic, we can use blocks or RF or cementation for vertebral fractures. For visceral pain, neurolytic procedures, or for refractory pain, the spinal infusion pumps. In this lecture, I'm going to focus on these two types of treatments that are very specific, not only for cancer patients, but we see a lot of patients with refractory pain that we need to use neurolytic agents or the intrathecal infusion pumps. So let's start with the neurolytic procedures for visceral cancer pain. The neurolytic procedures are interventions aimed at destroying nerve fibers that are involved in the painful transmission. The main indication is the cancer visceral pain. Most of the patients have unresectable tumors, and the target are the sympathetic nerve system fibers, are the fibers that carries the pain from the viscera. And we can use chemical agents as alcohol or phenol, or the conventional radiofrequency. It depends of if our target is very specific, or is more bigger. If we got a very specific nerve, we can use the conventional radiofrequency or a chemical agent. But if we had a plexus, very big plexus, we have to use the chemical agents. The visceral pain is very difficult to treat because it's a deep and ill-defined pain, frequently accompanied by autonomic features like headache or dizziness or nausea. And it has a viscerosomatic convergence at the dorsal horn. So the second order neurons receive somatic or viscerosomatic info. That's the reason why a lot of patients have referred pain. The referred pain is the pain felt at a distant site of the original pain, but that shares the synapses at the same spinal dorsal horn. So this visceral pain has multisegmental innervations. It has less nerve endings than in the skin. Has a close relationship with bone, myofascial, and visceral structures, especially in the pelvis. And the viscera have more wide dynamic range receptors than nociceptors. That's the reason why it's very difficult to treat. It's a challenge for us. The targets that we got are for the abdominal visceral pain. We got the splanchnic nerves and the celiac plexus. We will see the differences and the indications for these targets. And for the pelvic pain, we got the superior hypogastric plexus and the ganglion part for the pelvic pain and for the pelvic floor pain. And there are two other possible targets that are the lumbar sympathetic chains, but this target is preferable to treat pain from the limbs, for the lower limbs, in this case, vascular diseases or CRPS. And the inferior hypogastric plexus is another possible target that we'll talk about it. What about the evidence-based medicine of sympathetic blocks for visceral pain? We only have a couple of RCTs, and almost all of it are about pancreatic cancer treated with celiac plexus neurolysis. So we only have nowadays only one RCT about the superior hypogastric plexus block. The other ones are focusing the celiac plexus block for pancreatic cancer. And the problem is that the quality of the evidence of these procedures are very low. We only have 2 studies with a high quality. This is because a lot of bias, the low sample size, and the very common bias we got in a lot of studies. Okay, so that's the reason why the quality of evidence is still low. But does this mean that based on the evidence, we should not perform these procedures on our patients? Well, as Miles Day says, he says no, because these procedures are offered to patients whose pain has proven refractory to conservative therapy. These blocks can help to reduce the requirement for oral analgesics while decreasing tolerance and side effects. The benefits of these procedures outweigh the risks when performed by properly trained practitioners. So as physicians, we need to know our limits, and if we cannot safely perform the procedure, the patient needs to be referred to somebody who can do it. Okay, the treatments should be performed for diagnoses that are supported by the literature and when conservative therapy is ineffective. But I tell you that we are trying to do these procedures very early, especially in the pancreatic cancer, and we most of the times avoid the diagnostic block because we are trying to help the patient in the early stage. The reimbursement for these procedures is reasonable, as most can be performed in a clinic setting without sedation. The chemical agents that we use are the alcohol and the phenol. There are several chemical agents that have been used to reinterrupt the nociception. The ideal agent may be one that can selectively interrupt the A delta and C fibers, that are the fibers that carries the visceral pain. But unfortunately, all cause indiscriminate destruction of the nerve tissue. So we have to be very aware with the patient selection due to the possible risks that we got with these agents. That's why we try to avoid to use these chemical agents for non-cancer visceral pain. but there are some publications regarding the efficacy about it, but we're focusing here to the cancer patients, okay? The indications for chemical agents may be at the subarachnoid space or the peridural or directly over the neck fibers, okay? I will show you the benefits to treat the patients with the chemical agents over the nerve fibers. The main histopathologic finding is the Wallerian degeneration and the segmentarity desmyelinization, as you see in the picture. And the basal lamina of the Schwann cells persist after the neurolysis, allowing the correct regeneration of the nerve fibers, and so avoiding the neurinoma formations. So you have to know that these neurolytic blocks are very effective, but only for a time. So only for a period of 3 or 4 months. After that period, the patient may have the pain again, but we can repeat the procedure if we have a very successful result at the first time. What are the differences between the alcohol and the phenol? Well, the alcohol is at least in Spain, we got the alcohol in every surgery room. It's a very stable agent. You can keep it in the operating room. Unlike the phenol should keep in cold and should be prepared in the pharmacy of the hospital. The alcohol that we use is in between 50 and 70%, and the phenol is in between 6 to 10%. If we use phenol lower than 6%, the phenol will act as an anesthetic, okay? And if we use phenol more than 10%, we will have very high risk of somatic nerves damage, okay? The alcohol is hypobaric and the phenol is hyperbaric. And this is very important for the neurolytic blocks. The alcohol has more affinity for somatic nerves, and the phenol has more affinity for the blood vessels. So if our target is very close to important vessels, like for example the celiac plexus, that is very close to the aorta and the cava, it's recommended to use alcohol because the phenol has affinity for blood vessels. And if the target that we got is very close to somatic nerves, for instance, the splanchnic nerves that are very close to the thoracic foramina, it is recommended to use phenol to decrease the risk of damage of these nerves. Another disadvantage of the alcohol is that the injection is very painful. So you can or mix the alcohol with local anesthetic or inject some hypnotic drug to the patient to produce a very few sedation during the injection. And the duration of the neurolysis is in between 2 or 4 months. The celiac plexus and the splanchnic nerves is one of there are very common targets for the visceral pain in abdominal cancer patients, but these nerves or these targets innervates not only the gastrointestinal tract. It innervates the gastrointestinal tract from the distal third of the esophagus to the transverse colon, and the genitourinary tract from the kidney to the proximal third of the ureter. So theoretically, a pain coming from these structures could be managed by a neurolytic block of the celiac plexus or the splanchnic nerves. We'll talk about the celiac plexus. That is the best studied neurolytic block for the pancreatic cancer. That is one of the solid tumors with the worst prognosis that exists. The 5-year survival is only 5 to 10%, and more than half of the patients do not survive after the first year. This is because the symptoms appear very late, and the cancer, the pancreas is localized in a very specific region surrounded by structures that are essential for the life. So That's the reason why the survival is very low. And more than 80% of the patients will suffer from abdominal and dorsal pain throughout the illness, with 50 to 70% of severe pain. So this is very challenging to treat these patients. We got different approaches for the celiac plexus block. The classical one is the transcrural approach. You have to go through the diaphragmatic crura and put the needle in front of the aorta and the cava to do the block. It is the approach with a lot of evidence compared with the other ones, but it has a very high risk of complications, even the death that is publicated. There and we can use different imaging techniques for the neurolytic procedures of the celiac plexus. We can use fluoroscopy, we can use the ultrasound, the CT, the endoscopic ultrasound, and the MRI. As an anesthesiologist, I do the fluoroscopy or the ultrasound. You can use the CT if you can access to it. The endoscopic ultrasound approach is for the gastroenterologist, and the MRI it doesn't make sense because it's very expensive. So the fluoroscopy is very simple and fast, but the problem is that the only landmarks that you have is the bone. So you don't see the vessels, you don't see the aorta, you don't see the cava. So it's very risky, and I have quit doing the celiac plexus block with fluoroscopy because I cannot see anything but the bones. So I prefer to do this splanchnic nerves block, and I will show you why. There's a new technology that is the ultrasound for these procedures, for these neurolytic blocks. And the ultrasound, you can do it for the celiac plexus, doing an anterior approach. You have to go through the liver and towards the celiac plexus. I will show you some pictures, and you can use it for this target. You cannot do it the splanchnic nerves because the splanchnic nerves are very close to the bones, and it's impossible to see it or to identify it using ultrasound. So when do we use the celiac plexus block? With the celiac plexus block, the principal indication is the pancreatic cancer or other visceral cancer of the abdominal visceral cancer pain. We will use a chemical lesion here because it's a plexus surrounding the celiac trunk. So we will have we will need to use a chemical agent and a very high volume of chemical agents to destroy this plexus, between 20 to 40 milliliters of alcohol in this case, because the alcohol, because the phenol has more affinity for the blood vessels. And when we use these splanchnic nerves, right, we can use the splanchnic nerves block for the pancreatic cancer pain. When we want to do a combination between the two blocks, or when the celiac plexus block is contraindicated. For instance, when there is a tumoral infiltration, or when there is anatomical anomalies that you cannot see it using the fluoroscopy. Okay, the tumoral infiltration of the celiac plexus acts as an umbrella for the block. So if you inject the chemical agent, the tumoral infiltration in the celiac plexus avoids the neurolysis. So you would choose an splanchnic nerve block in these patients. So you have to check the CT, the abdominal CT of the patients every time you're going to indicate a celiac plexus block, because if there is a tumoral infiltration or anatomical anomalies, you shouldn't do this procedure. It's preferable to do a splanchnic nerve neurolysis. The splanchnic nerves are the nerves that are coming from the thoracic sympathetic chain and arising from there, and they are coming to the vertebral bodies from T5 to T12 and go through the diaphragmatic crura and joins the celiac plexus. This is a picture in the left of the celiac plexus neurolysis using fluoroscopy. And you can see that here we only see the bone structures and the contrast dye in the front, maybe with a beaten image. That means that this contrast is in front of the aorta. And in the right pictures, you see the celiac plexus using ultrasound. It's in between the celiac trunk and the superior mesenteric artery, and you have to perforate the liver and go towards the celiac plexus. So you have to check that the patients won't have coagulation anomalies. This is the materials that we use for these procedures. It's recommended to use needles that with a blunt tip, because we are going very close to the cava, to the aorta, to the lung. So it's preferable to use these blunt needles. And these are the skin landmarks for the splanchnic nerve in T11 and T12, and for the celiac plexus block that we're going from L2 to the anterior part of L1. This is a picture of a radio frequency of the splanchnic nerves. And this is the same patients with a contrast dye spreading. You can see here the contrast dye in the lateral part of the vertebral bodies. And you don't see an image of the lung or vessels that contraindicates the neurolysis. And this is a combination of the two blocks, the celiac plexus and the splanchnic nerves, to increase the success of this treatment. But you should know that you can increase the risk of complications too. The signs of successful block, the first one is, of course, the pain improvement, and you may have orthostatic hypotension and diarrhea because of the sympathetic block. These signs are signs of technical success, but not the outcome. The outcome is the pain improvement, okay? The complications are very uncommon. You can have infection, bleeding, pneumothorax, vessel puncture, chelatothorax, radiculitis, diaphragmatic irritation, paraplegia, or renal damage. And finally, some considerations about the celiac plexus and the splanchnic nerve blocks in the pancreatic cancer, that these procedures have a high efficacy of neurolysis in early stages, but the tumoral infiltration in surrounding structures reduces the success rate. Don't wait, please, for severe pain or for high opioid dose of these patients. The improvement of these procedures are time limited, so the procedures may be repeated depending on the life expectancy of the patient. Okay, let's change to another target, but this is for the pelvic cancer pain, the superior hypogastric plexus. The pelvic pain itself is very difficult to treat, because you can see here all the relationships with a lot of structures. The superior hypogastric plexus is localized over the L5S1 anterior part. Is the continuation of the lumbar sympathetic change, and it's very close to other structures like the inferior hypogastric plexus, the inferior rectal nerve, the pudendal nerve, the splanchnic pelvic nerve. So it has a lot of relationships, and most of the times the pain is not only visceral; it's a mixed pain. So that's the reason why the success rate of these procedures is less than the success rate of the celiac plexus and the splanchnic nerves block for the superior abdominal pain. But knowing that, we can use it in patients suffering from cancer pelvic pain. The classic approach is the posterolateral approach, or you can use a posterolateral approach or a transdiscal approach. Try to place the tip of the needle in the anterior part of the L5S1 vertebral body, doing the procedure there, doing the neurolysis in this area. And most of the times you have to use 2 needles to block all the plexus. There's another approach that is the anterior approach, described by Kanasi, but the anterior approach, you only can do it in patients that are not operated, that had not been operated in the abdominal side or the pelvic side, because if they are being operated, they have a lot of fibrosis, and you can have a perforation of the intestine. So it's contraindicated in that case. That's the reason why almost all the procedures we do in pelvic cancer patients are with a posterolateral approach, because these patients have been treated with radiotherapy, with the surgery. So the anterior approach is contraindicated. And there's only one RCT regarding the efficacy of this procedure. There's a lot of prospective and retrospective studies, but the evidence is lower than the other blocks that I mentioned before. And the complications are very uncommon, are related to common iliac plexus puncture, rectal puncture, radiculitis, renal damage, intraperitoneal injection, subarachnoid puncture, discitis, or bleeding. There's another approach described later, that is the inferior hypograxis plexus block using a transsacral approach. So this approach consists of placing a needle through the sacral foramina, S2 or S3, towards the anterior part of the sacrum. I use this procedure for non-cancer pelvic pain, because I try to treat the spinal nerves with radiofrequency, because I'm going through the sacral foramina, and then do a anesthetic block with corticosteroids to the inferior hypogastric plexus. But it's very risky to inject neurolytic agents using this approach, because you are very close to the spinal nerves of the sacrum. And finally, the ganglion part is the end of the sympathetic chain, and there's a few indications for neurolysis in this site. You can do a chemical neurolysis, or even a radiofrequency using 2 or 3 cannulas, doing a bipolar radiofrequency to perform a heating lesion of this ganglion for patients suffering from pain in the perineum, on the distal zone of the rectum, or the anus, or the distal part of the urethra, or the distal third of the vagina. And the summary for the neurolytic procedures is that the patient selection is the visceral cancer pain. Most of these patients have non-resectable tumors. The patients that suffering from pancreatic cancer are patients that with a very short life expectancy. For the abdominal pain, we use the celiac plexus block or the splanchnic nerve block. It depends of if the tumor is infiltrating some structures. The celiac plexus is contraindicated, and the splanchnic nerve may have less risk of serious complications compared to the celiac plexus, knowing that the celiac plexus is the best block studied in the literature. Okay, for the pelvic pain, we can have the superior hypogastric plexus, the posterior or transdiscal approach, and the ganglion impart, but with less evidence-based medicine. You have to consider combinations of targets to increase the success, but be aware of the risks. For tumors like the pancreatic cancer, you should perform these neurolytic procedures in early stages. And the objective is not only the pain relief, but also the quality life improvement. Because if you help the patients to relieve the pain, these patients will need less medications with less side effects of those drugs. And you should note that there is no publication regarding more life expectancy demonstrated with these procedures. Okay. And the other interventional technique I want to talk about is the spinal infusion pumps. It consists of the implantation of a pump connected to a catheter that is implanted in the spinal cord. Okay, the reason is, or the explanation is to administrate medications directly to the receptors in the spinal cord. So we will need 300 less dose than the oral drug, or 100 less dose than in the intravenous drug. Okay, and the indications are the patient suffering from refractory side effects due to opioid dose increasing, or patients suffering from refractory pain despite repeated increasing of the opioid dose, or patients that are not candidates for other treatments as neurolysis or spinal cord stimulation, or when these treatments have failed. And yeah, and it's very important to understand what's the definition of refractory pain. The pain is defined as refractory when multiple evidence-based biomedical therapies using a clinical appropriate and acceptable fashion have failed to reach the treatment goals that are the adequate pain reduction, the improvement in daily function, or have resulted in intolerable adverse effects. So that's the reason why the intrathecal infusion pump is not a salvage therapy. It's not a last resort therapy. So we have to treat the patients in the correct moment when other treatments have failed, but not as a last resort. Okay, and you should have to control the psychiatric disorders and psychological factors before indicate intrathecal infusion pump. Okay, and you can see here in the Polyanalytic Consensus Conference. This is a conference that started in 2012 to put together all the evidence base for the spinal infusion pumps, and to have some consensus for the topics that have no evidence. And they say that intrathecal therapy should not be used as a salvage therapy for failing systemic opioids, because if we do that, we will have bad results of this therapy. The patients will have opioid resistance. The patient will have the disease progression with complications, patient deterioration. The Polyanalytic Consensus Conference classified the cancer patients in three categories. There are three categories. The category 1 are patients with imminent death or life expectancy. The category 2 is patients whose disease is stable or slowed with progression. And the category 3 is patients with cancer in partial remission or residual chronic pain. So the patients that responds better to the intrathecal spinal pumps are the category 2 or the category 3 patients. But unfortunately, the patients that used to come to our office most are the patients with category 1. So another problem that we have is to deal with the oncologists and to talk to them and work together, trying to treat these patients in the correct moment and not very late. Which drugs we can use in the spinal infusion pumps? Well, there's a lot of drugs, but the only drugs approved by the FDA are the morphine and the ziconotide. The baclofen is used for the infusion pumps, but the indication is spasticity. So the first drugs that we have to think about in in a patient with refractory pain for a spinal infusion pump are morphine or Ciconotide. The morphine is, or we know the morphine is a mu agonist, and the Ciconotide is only used in the intrathecal space. It's an anti-calcium channel blockade, and it comes from this caracol. The name of the caracol I don't remember is the I don't remember the name. But we got more drugs besides the Ciconotide and morphine. If these drugs fail, we can change the drug or do the combinations. The side effects of the principal drugs are a lot of side effects. The morphine, we know the side effects of the morphine, meiosis, orthostatic hypotension. The respiratory depression is the worst that can do to the death. And the advantages of the Ciconotide are that it doesn't provoke tolerance, dependence, and addiction. But the principal or the most serious complication of the Ciconotide is the psychiatric complications, the psychosis or depression. The device that we used in these patients, now we got programmable pumps. You can design a personal dosage plan. This leads to the refills are spaced in time from 1 to 3 months. The half-life of these devices is for 4 to 7 years. These pumps are MRI compatible up to 3 Teslas. They got a lot of information with the tablets that we got, information about possible complications, refills, the volume of the pump, the drug that we are using are very safe. The complications of the pumps are a lot related to the patient, to the device, to the surgery, to the drug. So we get a lot of complications to keep in mind. The risk of infection is very low, 2.5 to 5% of the cases. And for meningitis is 2% of the cases. But we have to know all these possible complications, and we have to know how to diagnose it. About the life expectancy, there's a publication. There's only one publication that demonstrates that the patients treated with intrathecal infusion pumps lives more than the patients treated with systemic pharmacological treatment. This is a comparative study comparing cancer patients treated with intrathecal infusion pump and cancer patients treated with pharmacological treatment. And it's demonstrated the more life expectancy with the patients treated with the pumps with less adverse effects and more pain decrease. And there's another publication, very important publication about the cost effectivity, because the patients with refractory pain treated with spinal infusion pumps, with intrathecal pumps, have less health resources consumption than the patients treated with pharmacological treatments. Okay. So the summary for the intrathecal pumps are that they are indicated for patients with refractory pain, but not as a last resort. The drug selection, we should start with FDA approved morphine or Ciconotide, and if they fail, we can change or do mixtures with another drugs. Now we got programmable flux pumps that we got a lot of information with less risk of complications, and the life expectancy is higher with these pumps, and is demonstrated in the literature with less health resources consumption. So thank you very much for your attention. If you have any questions, I can answer you.
Thank you, Dr. Manuel. That was uh, precise, I can say, a precise talk on the overall topic and the subject of interventions in cancer pain, which in itself is a huge, I can say, a specialty or rather a subspecialty
Yeah.
of pain management. And you have tried to concise and make a proper package uh, delivered to our participants. So we are open to questions over here from the participants. Mahesh, over to you.
So I believe that the participants can put in the questions on the Q&A section and we can start taking them. If there are any live questions for Dr. Manuel.
Live questions. Yeah.
Yeah, because the interaction, if I believe, is restricted only to Q&A, so we can take the Q&As in between. There are no open questions at the moment. Any comments, Professor Raghu?
Yeah, so I mean, if no one is asking, I would like to put certain questions to Dr. Manuel, if you won't mind.
Yeah.
Now, there's a lot of dilemma in the physician's mind. At what time or what is the appropriate time to give an intervention? To
Yeah.
this?
The correct time. What is the correct time to these interventions? You mean?
Yes.
Yes. The problem is that the correct time is depends not only of our indications. It depends of when the patient is coming to our office, and that's the reason why we have to work very close to other specialties as the oncologist or the radiotherapist, because we see a lot of patients that come in very late to our clinic. And most of the time it's because maybe the oncologists, they don't know what we can do for these patients. So when the patients are coming to our clinic, maybe the patients are with a high dose of opioids, with a very, very low quality of life. Maybe the tumor has an infiltration of other structures. So all the tools that we have and the procedures that we can offer, maybe the success decrease a lot because it's very late for the patients.
That's true. So
Yeah.
it depends on what stage of the disease trajectory the patient is really, and also to take into account whether it is truly a pain which is not also managed by your opioids. If the patient is already on opioids, then it's certain to really to take a call. Again, it depends on what practice or where is your practice. For example, a person like me who is practicing at a tertiary center, so the patient is referred to our palliative clinic, and all of a sudden the patient is naive, is not on any analgesics and is already advanced. So there are many challenges, like, right at this point, whether we should give a intervention or we should give him an opioid challenge first and then see, because these patients do come from faraway places. Then again, it depends on the variations and what exactly the patient is coming for. So all these logistic issues also have to be taken into account when you are deciding this intervention. So we have a few questions also from our audiences. Mahesh, would you take a
Yes, so the first question is from Dr. Gaikwad from India about the treatment of refractory radiation enteritis and vaginitis, basically most RT pelvic pains.
The treatment with refractory radiation enteritis and vaginitis, or different syndromes, the enteritis and the vaginitis related pain. Well, it depends of the patient. So you have to study each patient and what about the characteristics of the pain, because this type of pain are used to be mixed pain. So the patient will have visceral pain, maybe somatic pain or some neuropathic features. So it's very, very difficult to treat them. And I think that not only with one procedure you can help them. So you will have to do more than one procedure. You will have to treat it with drugs, with a pharmacological treatment, with a neurolytic block, maybe with some radio frequency in the pudendal nerve. So very, very difficult to treat this kind of patients.
There's a question by Dr. Savari. Dr. Raghu, can you answer this about identifying?
Yeah, so identifying the vessel, whenever you are inserting a needle, you aspirate. First point, that's the basic thing. That is how you identify whether you are in the vessel or tangentially just touching the vessel. You may get some aspiration, some blood. If you are getting even some blood, not a free flow, you just withdraw the needle or you try to go deep. So this is the first thing, which is the thing. And second thing is that when you inject a dye, you take a live fluoroscopy and you see whether your dye is getting washed out. So these are the ways by which in a fluoroscopy you can identify whether your needle is there near the vessel or it is really injured your vessel.
The next question is from Dr. Narula from India about going with the needle perpendicular under fluoroscopy, like in a paravertebral block instead of needle in an oblique view. I'm not sure about the phrasing of the question.
Perpendicular under fluoroscopy. Okay, I think I understood it. For the Spanish block, the needle perpendicular under fluoroscopy, like we do the paravertebral block. So when you perform the splenicular block, you have to do some oblique view. You cannot go a pure perpendicular approach because the nerves are crossing the lateral parts of the vertebral bodies. So you have to go towards very close to the vertebral body. It's very useful to use curved tip needles. And you have to use a lot of oblique view, not too much oblique view, otherwise the lung will be in your pathway. So, but you have to go for 5 to 10 degrees of oblique view, but it's not the same approach as the paravertebral block. It's different.
There's a question on head and neck cancers. A lot of it in India, we treat a lot of neck cancers. Dr. Raghu, would you like to take that up?
Yeah, no worries. So, yes, true. In India, we encounter the major component of our cancer is head and neck cancers, followed by colorectals and others. But head and neck is a major chunk. And yes, there are many interventions which can be performed based on the type of pathology. Where exactly, I can say rather than pathology, I can say where exactly is the location of the cancer, whether it is a buccal mucosa, whether it is a base of the tongue, and what sort of pain distribution the patient is having. So all these things have to be taken into account, or whether the patient is post surgical and all those things. So means to give a few examples, for example, if it is a base of the tongue, most of the time the patients do present with your nociceptive pain along with your neuropathic component, which includes your glossopharyngeal nerve. So that time you can give a glossopharyngeal nerve block under fluoroscopy or under your ultrasound guided. So there are techniques which have been already described, all these things. Second thing, for example, if the patient is post-operative and if has underwent a command of, for example, a hemimandibulectomy with a free fibula or just a PMMC flap, these patients do come up with a neuropathic pain, V2, V3 distribution. You can say a secondary trigeminal neuropathic pain. So again, you can do a V2, V3 radiofrequency ablation in this group of patients, or you can do a neurolytic blocker in this group of patients. And it's very easy because the foramen ovale is just open because there is no lower alveolus. So it's a very easy group of patients in which you can do this. And other third interventions, because there is a lot of neck dissections, they do come with myofascial component of pain, and where you can do a lot of myofascial manipulations with needles. I can say the trigger point injections or dry needling. So all these things you can do. These are the interventions you can perform for head and neck cancer patients.
Thank you. That question was from Dr. Deepak from India. We have another question by Dr. Suvari about asking the patient on the table, the pain has reduced, what do you use for assessment? I like one line that you mentioned, that seeing the fluoroscopy spread is actually a marker of a technically good block, but not necessarily pain relief. So
yes, I don't ask the patient in the table about the reduction of the pain. I always wait for 1 or 2 days, because if I am doing a neurolytic block for the stellar plexus, for example, and I am using alcohol, I have to sedate the patient, and most of the times the patient don't know, the patient doesn't know about the reduction of the pain after 1 or 2 days. So I keep the medication after 1 or 2 days, and then I will ask about the reduction of the pain. I will visit the patient the day after, of course, but it's not a result that you will see on the table. So you the chemical agent will have to do its work and do all the destroying of the fibers, and it lasts for 1-2 days. Okay.
There's a question by Dr. Gupta about any specific sites where interventions do better than other strategies, but I think you already mentioned the evidence for sympathetic blocks about intrathecal devices. So if you're talking about evidence, these are some of the areas like pancreatic cancer and so on. Anything else you wish to add to this? Any specific site?
Any specific sites? I don't know. I don't understand the question.
Like any specific site, for example, is it head, face, neck? If I'm trying to interpret this as well, whether it's head, face, neck, or thorax or abdominal malignancies. But I think you already mentioned it in your talk. Pancreatic malignancies, there is literature, and intrathecal, there is literature for generalized.
Yeah. There are other sites and other tumors you can use these procedures, but the problem is that the most of the evidence is regarding the pancreatic cancer. This is one of the worst painful tumors at the abdominal area, but you can use it. I've been used not for cancer pain, but for renal pain in the kidney, but not cancer renal pain. I've been using a radio frequency of the splanchnic nerves, and it works.
I would like to add over here, Mahesh. Means what I understood from the question is that whether the intervention is better than pharmacological measures in certain type of.
Yes, better from the cancer patients will they always have medications before these interventions. I don't indicate the annurolytic block if the patient is not treated with medication. So you have to as I mentioned at the beginning of the lecture, I talk about the analgesic lift. So the patient, if the patient have a severe pain, they have to be treated with strong opioids. And you can also indicate the neuroleptic blocks depending on the source of the pain, but the patient should be treated with this pharmacological treatment, because the patients maybe are referred to you after being treated with their doctor, no? So this doctor may started this medication before you.
And one more thing is that means I would like to convey to the participants that you have to remember that interventions are not all means the only treatment therapy for cancer pain management. If your pharmacological management fails, they are just an adjuvant. So that is what is the major thing you have to remember, because I had encountered many students who come to training under me and they ask, so if I do interventions, there is a 100% pain relief. I don't know. Because they really need to understand this concept of that interventions are adjuvants. So
this leads us to the next question by Dr. Patel about Lolo, you have any experience with yoga in cancer pain? Do you, in your institute, in your centers, do you use yoga and other non-pharmacological methods?
No, I don't have experience of yoga. I don't know if you have experience, or Raghu.
No, I think sometimes when with difficult patients, we need to do yoga to calm down and realize that.
But I don't have experience about that.
But yes, we do have one yoga center. We used to have. I don't know at present now we are having it or not in our institute, and patients used to go there and to do certain stretchings and all. And but we haven't really focused on how many patients have really got benefited. But yes, they do go and they say.
I'm sure that will be a role. I'm sure.
But we don't have any statistical evidence to state that it really helps.
The next question, Professor Raghu, you want to take it on phenol or alcohol in celiac plexus?
Yes, for celiac plexus, it is always alcohol. So it's never a phenol. And as it was already mentioned by Dr. Manuel, right, he has very beautifully explained the differences between these two neurolytic agents which we use, phenol versus alcohol. And he has said that this phenol has an affinity for the blood vessels. And if you see celiac plexus is just right over sitting at your celiac trunk on the abdominal aorta. So to be very careful when you're using phenol in such group of patients. And again, one more thing you have to understand is that the availability of phenol, because phenol has to be always freshly prepared by your pharmacist, whereas alcohol,
Yes.
no need. So, and
Yeah.
phenol, the viability of the phenol is also a question, because how long you can store it, and the sterility also matters. So no one knows if you store it for 3 days whether it is really sterile, it will be, the sterility is maintained or not.
Uh, the next question is by one of our faculties who helps out with educational activities, Dr. Tushar. He's asked about the RFA at T11 and T12. Manuel, where would you prefer to do the radio frequency ablation for the splanchnic nerves, at T11, T12, or just at T11? And any difference in
I always do the T11 and T12 is the procedure that is described in all the, the books that I read and the publications. Is because these nerves meets in these two levels, and if you place it the 4 needles, you will have more right of success. There are sometimes that you place the needles, and sometimes one needle you have a contrast dye spreading of a vessel, for instance, and you cannot use this needle, but it's preferable to use the 4 needles in the 2 levels to increase the rate of success.
Okay. The next question was by Maureen Lukman about going straight to interventional pain management, which we have answered, and about using spinal pump infusions and about patients for home care. But that again, it depends upon how you're allowed to dispense opioids out of hospital. I guess it's
Yeah.
Yeah. But logically, it makes sense if a lot of patients do go home over the
Yeah,
world.
no, the indication of the spinal of the intrathecal infusion pumps is to try to have the patient at home and not in the hospital, so that the patient can manage their pain at home and not the hospital. That's the indication. Sometimes, and the people that don't know the spinal infusion pumps used to think that maybe it's because the patient is dying, so the patient is at the hospital and and he or she needs this pump. No, this pump is because the patient is at the hospital, and I want that the patient should be at home managing the pain. So that's the reason why we use this treatment, and that's the reason why the patient should have a life expectancy more than 3 months, but it's very difficult to calculate that in most of the cases.
We have just a few more questions remaining. There's one about leptomeningeal involvement, a patient with cerebrospinal fluid metastasis and headache. So what would your strategies be? We'll take Dr. Manuel's question, Manuel first, and we'll ask Dr. Ravu.
Treatment of patient with
Headache because of cerebrospinal fluid involvement.
I think I understand. I don't understand the question.
So there's a patient
So
with metastasis
patient
with
with
the meninges, yeah, and this patient is having headache because of the meningeal involvement and raised ICP or whatever reasons.
yeah, so the patient has severe headache due to the metastasis of the
Yes.
cerebrospinal fluid.
Yes, yes.
Okay. Well, yeah, let me think about it, because well, it's a very difficult state, but these patients, the problem of the metastasis in that area is very difficult to treat. I'm trying to think about an alternative interventional technique, but I don't know if you have more experience in that.
So
Dr. Rahu, yeah.
So now you have to understand this. The patient has already a metastasis to the CSF. I will really need to evaluate whether the patient's even meninges have been involved, and you have to always also see whether even the brain has been involved. And now the patient is having severe headache. Okay, and that means that means that the patient already is having a brain metastasis, could be, or just leptomeningitis.
Yeah.
So we have to understand this. So again, it goes, suppose if the patient is having a brain metastasis, then you really need to think whether the ICT is raised. Okay, whether he is having another symptoms associated with it. Even if it is not there, it is not always necessary that you should have nausea or vomiting if there is a raised ICT. So you can go with your dexamethasone, mannitol regimes of decreasing your raised ICTs. And these regimes do usually help a lot in the patients who come with CSF metastasis, brain metastasis, or leptomeningeal metastasis.
Yeah,
So,
but- yeah.
in this group of patients.
Yeah, but we were thinking about we were thinking as a pain physicians, but there are a lot of treatments like that we can help the pain of the patient, like the radiotherapy for instance, or the chemotherapy. There are other instruments to treat this
There are some
patient, not only
centers where they do intrathecal chemotherapeutic agents. Intrathecal.
yeah,
If the ICP is
intrathecal.
normal, they inject intrathecal chemotherapeutic
Yes.
agents to these patients.
Yeah.
And
Any
even
experience with cryoablation?
therapy can also help in this group of patients.
Any experience with cryoablation? We don't have.
Yeah, I have less. I had a patient. The problem of the cryo in Spain, the cryo is very expensive, and it's very difficult to ask the hospital for a cryo device, because we got a radio frequency device, but the cryo is very expensive, and for the private hospitals, most of the company insurances don't cover it. So I have very few experience, but I had one patient with a tumor infiltration of intercostal nerve, and I did a cryo, and it worked without a motor dysfunction, because the cryo produces the lesion in the very small fibers. So the large fibers, the motor fibers, are kept working. So there's not a motor dysfunction with using the cryo. That's one of the indications, is the neuropathic pain in motor nerves or principal nerves. You can use the cryo because it's different from the conventional radiofrequency, that you can produce them motor dysfunction.
You have a couple of minutes. We'll finish off these questions. Just a few more, and then I think we will the last 5 questions.
Okay.
Of which one of them is about differentiating between pelvic and abdominal cause of pain. So what do you do if you have a patient with an visceral malignancy and you are not able to differentiate whether it's pelvic source or the abdominal source?
It's a very good question, because the point is it's not easy to distinguish between abdominal and pelvic. But sometimes the patient is telling you that the pain is in the whole area of the abdominal wall and the abdominal side and the pelvic, and it's very difficult. So, but you have to know where is the original tumor, where it is. So sometimes the pain, the patient have pancreatic cancer, and you know where is the tumor, and the patient is telling you that the pain is going to the abdominal part, or to the pelvic area, to the dorsal area, but you know that the original problem is in the pancreas. So in these cases, you can go to do a neurolytic block of the celiac plexus, but there are sometimes, especially in the pelvic structures, it's very difficult. So you have to study the additional tests, not only the anamnesis of the patient or the physical examination, but the additional tests. Another test that may show you where is the principal problem, because you have to start treating the principal problem. Maybe there are other secondary problems of the patient, and sometimes the pain, as you asking, is very extensive.
Just 2 more questions. One is about consent. How do you take consent of a patient while you're explaining? There's a practical question about neurolytic blocks. And the second question is an extension of a previous question about vaginitis. So the patient with an enterovaginal fistula getting burning pain during contamination because of the rectovaginal, the enterovaginal fistula.
Yeah.
There are 2 questions.
So,
last 2 questions.
Two questions. The first one is, how do you take consent of patients, especially while explaining fear dangerous complications of neurolytic block?
Yes.
This is the first one. Okay.
Yes. Yeah.
The consent, or you have the consent, the paper consent to explain you always have to explain all the possible benefits, all the expectatives, and all the risks of the patient. The patient should know that maybe these techniques will help them to reduce their pain, but not to alleviate all the pain. And the complications are very important to explain for the patients, to tell them that they're very, very uncommon, but exist, and they have to sign a paper with all the consent.
And for the
The patient should be informed of all the complications, all the possible benefits, always.
always. So this
And
question,
the other one,
about an iliovaginal fistula with burning pain, vaginitis, kind of a severe pain. So what would your approach be? What kind of interventions will you target, or how would you think of it?
well, the problem here is the fistula is the problem is that this patient has a fistula that is not so is the source of the problem. It is cyst, and it is still provoking the pain. But sometimes you can do a ganglion impart block, and in these patients maybe you will have some pain relief, but the problem is still exists. This is the fistula, but in these cases you can use the ganglion impart block.
All right. Professor Raghu, any comments now so far? Because we had a very interactive audience, and a lot of them have been.
You are asking about this question. Any comments or?
Yes, yes. In general, yes, yes. Because we've used inferior hypogastric blocks in 3 patients with severe pain. And
see, again, now this rectovaginal fistula is a very common complication in this CS cervix patient, and always it will be there. So now, infection control is the most commonest thing which we have to do. Okay, that is the major part, infection control. So you have to see the count, so that the patient is having fever, all these things. I have to first take care of that. Second thing is the nursing. Okay, so the nursing component adds a lot into it. So that is the hygiene, to maintain the hygiene, to clean the genital areas properly with the available. What we usually do is that we tell them to prepare a douche of metronidazole along with normal saline, and you just place it inside, and that takes care of that local infection and the irritation. And along with that, we also try to give a certain steroidal, because these two patients also have proctitis along with this vaginitis pain, and we try to give them some steroid enemas sometimes, and they also help, other than apart from the interventions like ganglion import and inferior hypogastric plexus block.
So thanks, Manuel, for coming and taking your time out, and thanks to all the or in the audience who've been very interactive, who've been very patient, and who attended. And best wishes. I hope there is some value added after this lecture to improving your practice, and we can collaborate with each other, because COVID has taught us at least this thing, that we can all work together. And there's a huge area of need, especially in India and all over the world, I believe, for cancer pain. I would just like Professor Raghu to conclude and say a few words.
Thank you once again, Dr. Manuel. A huge task, small compact package. I hope all our participants are really will get benefited by this profound knowledge which you have given to them. And it was really wonderful, and most important was the interaction with our participants. So the way they have asked the questions, it really states that how enthusiastic and interested they are, and certain questions really made us to understand that yes, these people, certain participants are really practicing cancer pain component as a physician. So overall, it is a nice one, and hope we continue to have such academic fiestas in collaboration with your institute, Dr. Manuel, in near futures. Thank you very much, and once again, and on behalf of our Integrated Pain and Palliative and the Smart Pain International. Thank you.
Thank you, man.
Thank you so much. Thank you for your invitation, and looking forward to collaborate more times with you. Take care.
Bye. Take care. Bye.
Bye.
Bye, Prof. Raghu. Bye.
Bye, everyone.